Hello, my name is Alan Waterman, and I'm representing the MediTouch team here. Um, I'm a movement and exercise physiologist, and I've worked for a number of years on the development and also the clinical use of the BalanceTutor, which is a perturbation-based reactive response treadmill. And I'm joined today by Amy Downing. So, Amy, hi. Do you want to just introduce us, please?
Yes, hi, my name is Amy Downing. I am a physical therapist in Missoula, Montana. I have my own practice. It's an outpatient private practice that specializes in vestibular rehab. We also do neurological cases and orthopedics. I have been a physical therapist for over 30 years. I also teach the vestibular trends course at the University of Montana, and I really enjoy what I do. I own the BalanceTutor now for, gosh, going on a year and a half, 2 years. And we use it exclusively at our clinic to assist our patients get better on a variety of levels. So it's worked out great.
Okay, well, thank you very much for the introduction. And we're going to be together for a couple of sessions, and we're going to base our talk on a PowerPoint presentation where, as I said, we're going to be looking at both the technical aspects and the clinical aspects of the use of the BalanceTutor with many clinical examples. So I'm sure you're all going to enjoy the presentation that we're going to be doing. Okay. I think we agreed, correct, Amy, that we wanted to first of all start with, as a basis for our talk, um, just a little bit of introduction about what the BalanceTutor is. Okay,
Correct.
so the BalanceTutor is a perturbation treadmill, and it's a treadmill that can move laterally to the left or to the right, and it can also the treadmill can actually obviously go forward or backwards, so we can introduce anterior and posterior perturbations. So we can do this while the client is standing, or we can do this while the client is in gait as well. And that gives us a lot of treatment options to be able to challenge our patients with what we call unexpected perturbation. So we're going to go into what exactly perturbation-based balance training is and how we use the BalanceTutor for this later in our presentation. I think what's very important, and we both agree with that we would start the presentation looking at sensory integration, because when you're looking at balance and gait training, obviously you're looking at balance and gait training for a variety of indications, both neurological injury and disease patients, even elderly patients. Obviously, you're going to have deteriorations in balance and gait, and also the orthopedic element, some traumatic injury, obviously lower extremity injury, you're going to get some deficits in balance and gait. And I think a very important, if you like, underlying deficit is going to be the deficits in sensory integration. The fact that you have deficits during neurological injury and disease of proprioception, you have deficits with the vestibular sensory organization and control. And also, to a certain extent, if you're looking at peripheral injury, you've got some damage to peripheral neuropathy, for instance, some peripheral elements of damage to proprioception. And with elderly patients as well, you have patients that obviously, as they're getting older, they get a general deterioration in their ability, in their sensory integration ability. And this obviously results in deficits in gait and balance. But I think other things that we can also think about deficits in sensory integration are even, for instance, dementia patients. That they're going to get some deficits in, or that's probably an underlying reason that they're losing their mobility and losing their balance and gait. So there's other out of the, if you like, out of the general picture of why we should be looking at sensory integration as a starting point when we're looking at balance and gait. Amy, have you got anything to add to that at all?
No, I really appreciate the slide because it shows the midbrain, it shows the brainstem, and it kind of reminds you that that's, you know, what we're activating are some of these reflexes that are located in the nuclei located in the brainstem and throughout the brain. So I agree with the sensory integration. That's an important concept to understand before we go into the BalanceTutor.
That's correct. Okay. And another important concept as well is what are our balance strategies, our balance and postural strategies, and how can we use if you like, a physiological and a clinical understanding of these strategies to actually dictate how we're going to do treatment. I think that's a very important element as well. So we're going to look at postural control strategies, and broadly speaking, we're going to divide those up into two sections. The first one is anticipatory postural adjustment. So we have a short video here which shows this girl negotiating, if you like, obstacles, common everyday obstacles during an ADL activity that she has to, if you like, sense that they're coming up. Okay, she has to do the appropriate weight shift to negotiate the challenge to her balance and gait, and then continue with her everyday whatever the function is that she's trying to continue with. So obviously she needs a certain muscle coordination strategy, a certain planned muscle coordination strategy to these obstacles. So we can very much talk of these obstacles as perturbations to her gait, but these perturbations to her gait are expected. So to negotiate it, she's doing a planned coordination strategy to shift her center of mass before she comes across the challenges to the gait, so that she can actually negotiate these challenges and carry on going forward. So that's an example of an anticipatory postural adjustment. So it's a particular set, in conclusion, of muscle coordination strategies that we do when we challenge, if you like, to expected perturbations, to everyday life issues that we know are going to be coming up and we can plan for in advance. Now, if we have a look at if you like, in the right-hand pane here, if we play the video, what's actually happening here is an unexpected perturbation. That trip or slip is actually shifting the center of mass, which cannot be expected. It happens unexpectedly, and it causes some sort of a reactive-like response to maintain balance, whether that's going to be a reactive weight shift or a reactive stepping action. But what's actually happening here is the sensory system picks up on the change or the shift in the center of mass, and then we have to react. And this goes very much back to what Amy said as well. That information, that afferent information, is obviously passed to different areas of the brain, or or if you like, controlled by different areas of the brain. Very much the midbrain areas, as Amy was saying. So as well as looking at a different coordination strategy that we are challenging when a compensatory postural adjustment actually happens, we're obviously challenging as well the integration, or different areas of the brain to do the integration, and obviously different neural networks are going to be at play. So the concept here is very much we have to understand the difference between an anticipatory postural adjustment and a compensatory postural adjustment. Amy, have you got anything to add at all?
Yeah, I think that's a great video showing that when we talk about sensory integration, we're able to move. It's almost to the limits of movement that allows us to go. So it's important, I think, to understand that if somebody doesn't have a well-integrated sensory system, then their movement is going to be as agile as that looks right there. So
Yes.
it's important to address that, because those are the challenging times when our patients tend to fall, is when they're not expecting it. So
Okay. Okay. So this is just now a video showing what's happening in normal gait. Obviously, the normal gait, the center of the center of mass, is moving in a cyclical fashion. In terms of our weight shift. So it's our activation of the muscles of the lower leg or the limb and the trunk, which is allowing us to, if you like, keep our center of mass within our base of support. But this is done in a very planned and methodical way, a very cyclical way. If we can compare that now to what's actually happening with a trip or a slip,
sorry.
the trip or the slip, the center of mass is being shifted, as I said earlier, and then we have to react to that shift. So we have to do some sort of a reactive-like response to be able to maintain our balance. So if we look into the literature, we find that way back in 1992, Masson has actually defined what an anticipatory postural adjustment is. As I said, it's the control of the position of the center of mass by activating the trunk and leg muscles prior to a forthcoming perturbation. So prior to this expected perturbation. And obviously that's where you can maintain your equilibrium and you can maintain, if you like, that propulsive force and move forward. So if we look into the literature now about what a compensatory postural adjustment is, this is initiated by sensory feedback, okay, which is telling us, if you like, the feedback that our center of mass has suddenly been shifted relative to our body. And then it's allowing us to do some sort of a reactive response to reposition that center of mass so that we don't fall down. So what we're actually showing here, again, is in the first pane, the top pane here, where, let's just stop this here. So we have the first pane here. Obviously, as I say, very much like this everyday activity, okay? So the sensory information is fed forward, okay, to allow us to change our gait or to adapt our gait as we're doing a set of voluntary movements. Whereas a reactive response, that sensory information is fed back. So the information about our center of mass is fed back to allow us to do a reactive response. And then how we negotiate this challenge, this unexpected challenge, all the sensory information from what we've actually done from this negotiation is then fed forward for us to try and carry on with the initial task. So if we take sensory information as our initial, if you like, if we're doing an anticipatory postural adjustment, where we're getting this constant sensory information that is allowing us to constantly, if you like, change or replan or change our planning. So at first we obviously got the functional task, so we got the task planning. The sensory information then comes in, and again we choose the appropriate strategy, the appropriate muscle coordination strategy to be able to negotiate any perturbations, any unexpected perturbations, and keep with our task planning. And then we're getting this continuous loop of the sensory information being fed forward. If we take a compensatory postural adjustment, we have first of all the unexpected perturbation, which is picked up by us, the sensory system. The afferent information is then fed back to, if you like, as we said, more the midbrain area of the brain in a medium latency type of reactive response to actually allow us to do a certain coordination strategy to negotiate the perturbation. So what this slide is looking at here is really the latency, how long it takes for a reactive response relative to a voluntary response. So the studies have shown that a reactive response time is what we call out as a medium latency. So it takes between about 250 and 300 milliseconds for us to be able to initiate a reactive response. This is compared to obviously something about 500 milliseconds for a anticipatory postural response, which is working with cortical areas of the brain. Okay, so this time latency is very important because when we're designing our perturbations, we have to bear this in mind for that, for the unexpected perturbation, how we design the unexpected perturbation. So how we design the acceleration medially or laterally or posteriorly or anteriorly. Okay. Have you got anything to add at all about the latencies and about this slide, Amy?
No, I think it's a very straightforward slide. Clinically, to apply that, it's very difficult to apply a reactive force in the clinic for the patient, because a lot of times what people will do is hang on to the gait belt and then give them a force either forward, backward, or to the side. However, a lot of times we've explained this to the patient and we tell them, a little bit about what to expect. And so it's very difficult to get that reactive response in that time frame that we need clinically without the use of equipment, so to speak. So I think this is a great reminder of how quickly a reactive response occurs.
Oh, that's right. That's right. And we obviously have taken that very much on board to how we customize those perturbation amplitudes, or some people call them intensities. And we'll go into some details of that later. So this is now an example of a different coordination strategy. What's actually happening here? It's a shame that Amy wasn't putting the bottle into my left hand, but somebody's putting the bottle into my left hand. And I want you to look at the amount of elbow extension which is occurring as the bottle is put into my left hand, okay? Now I've got my eyes closed here. So it's, if you like, an unexpected perturbation. It's an unexpected perturbation to balance. It's causing me to have to react, to do some sort of a weight shift. But I can also see that in the amount of elbow extension which is happening, okay? Now, if we compare that here to myself doing a self-transfer of the bottle, then I know I'm going to transfer it. It's exactly the same weight of the bottle, okay? It's, if you like, the same force as the bottle goes into my hand. But you can see that I've already anticipated that bottle coming. That's why it's an anticipatory postural adjustment. So if you like, I'm flexing my biceps beforehand because I know the bottle is going to be coming in. So this is a good example of different coordination strategies at work. Now, obviously, when we have a deficit in one of these coordination strategies or one of these reactive responses, so what's happening? Obviously, there's a collision between this person's feet, okay, and he doesn't have the appropriate speed to actually implement that reactive response, okay, and that results in a fall. So again, he's got a certain amount of time, because gravity is at play here, for himself to be able to do that reactive response. Okay. So what's new I think it's very important that we have shown now in the literature that if we practice a reactive response, if we challenge our clients to unexpected perturbation, we can actually improve that reactive response. So just like that person in the CCTV video, if he had been challenged previously, maybe he would have the appropriate speed or strength or reactive response or sensory integration ability to actually implement that strategy to actually make him or prevent him from falling. So reactive response strategies can actually be trained. And so balance recovery strategies can be trained. Okay. Now, the thing is, how do we train these? Is it possible to train these in the clinic without using a technology to give unexpected perturbation? And the evidence from 2010, from this 2010 paper, said no, that in order to be able to train reactive response, you have to challenge the patient with unexpected perturbations, and challenging the patients with expected perturbations or voluntary exercise practice will not actually improve their reactive response strategies.